So I'm going to just take the liberty and play it for like 5 minutes. If there's someone from the next session here, please come forward. Volume.
So my topic for today is the complex mind.
It's attached.
To include cases which toys very close to his face. The cycloplegic refraction revealed a refractive error of -8 in both the eyes, and the fundus picture is as shown, like a myopic tessellated fundus. The child has been on regular follow-up. The parents were concerned with such high onset of myopia in such a young age and were obviously curious to know if something can be done for the management. So we have just been following up this kid regularly, and the refractive errors have been stable for the last 4 years. So what is this type of myopia? So this is a type of congenital myopia. So let us look at the features of congenital myopia. So we have high myopia with onset in infancy, but the refraction tends to remain stable. It has been reported that the refractions remain stable till up to even 20 to 30 years of age, which has been the longest follow-up. And the fundus has very typical features of a tilted myopic disc, a temporal conus, and a posterior staphyla. Moving on to the second case, this is a 5-year-old child. This is a known case of high myopia on glasses since 2 years of age. There's a positive history of myopia in the family. The current glasses that the child is wearing is of -8. Parents feel that the vision has reduced than before and the glass power has been increasing. There has always been a history of the child taking off the glasses while viewing nearer objects. A cycloplegic refraction revealed that the myopia has increased to -11. This is a fundus picture of the child showing the myopic fundus with some myopic maculopathy. So what is this type of myopia? So this is the type of myopia called as a pathological myopia. So we know that when the myopia is more than -6 to -8 associated with fundus changes, we call it as pathological myopia. Now, the parental concerns was the child is so young, the myopia is likely to progress, and can any intervention be tried to try and reduce the progression? So we obviously try to look up at the literature to see if something can be done. Say 3 to 4 years back, we were not doing any pharmacological intervention in the form of atropine drops to try and reduce the progression. However, this study has probably changed things in that context. So this was a study that studied how low-dose atropine drops were effective in children with high myopia, where 60 eyes of 34 children were included. And the refractive error bracket that was studied was high myopia in the range of -5 to -16.5. And this study showed positive results with myopia progression being controlled from baseline to second year, with the control being better in the intervention group as compared to the control group. And they concluded that low-dose atropine drops can be used in high myopia as a measure to reduce progression. So even in the high myopia cases, this option does stand for us as a control measure. The other option is an optical control, wherein progressive lenses or multifocal soft contact lenses can be used, especially if the child is an accommodative lag. So I would like to say that the correct estimation of the accommodative function of a child having myopia is also extremely important, because there is a good subset of kids who do have a bit of an accommodative lag, and a progressive lens or the multifocal contact lens is a good viable option for control of myopia progression in them. Also, when we administer the low-dose atropine drops, that causes further lag in the accommodation, and they become really symptomatic for their work. Moving on to the third case. So this was a 29-weeker kid who presented with aggressive ROP as is seen in the fundus picture. The child underwent intravitreal injections followed by laser for the ROP with good regression of ROP, and the child has been doing well with respect to that. However, at 8 months, the child presents with squinting of the eyes and very high refractive error in the range of -10 with an astigmatism of -3 and -2 in either eye. So what is this type of myopia? So this is myopia associated with premature. So what is different about this is basically in premature babies, the ocular structures are still immature because they leave the uterus at a time when the ocular growth is not complete. Refractive media is formed in the last embryonic phase or just after birth. So when the babies are born early, it results in the arrest of the ocular growth. So what I mean by arrest in ocular growth is basically the normal emetropization process gets changed. So axial elongation of the eyeball is halted. The lens remains thicker and is anteriorly placed. The cornea remains steeper and the anterior chamber remains shallow. So the myopia in these kids is not of axial origin is one thing that we need to note. So, is the refractive error likely to progress? Is the common question that pediatric ophthalmologists are going to get. So, myopia of prematurity is a spectrum as is shown here. So, it begins with myopia of prematurity, to myopia of spontaneously regressed ROP, and myopia of laser ablation. So, myopia of prematurity is likely to resolve by say around 8 months to 1 year of age. Myopia of spontaneously regressed ROP plateaus by 2 years of age and tends to remain stable, while myopia of laser ablation tends to give low to high myopias. Even in these subset of kids, the myopia tends to progress between say around 2 to 4 years of age. Then it tends to stabilize and sometimes can even reduce as uh, the lens thickness and the corneal deepening tend to go down. Moving on to the fourth case, is a 7-year-old child presenting with history of using glasses since 4 years. There is complaints of diminution of vision in the right eye since childhood in spite of use of the glasses. So the glasses power that the child is wearing is -4 in the right eye and the left eye is a plano correction. Vision with glasses is 6 by 24 and 6 in the right eye and 6 and 6 in the left eye. Current refraction revealed right eye to have a refractive error of -7 and the vision improving to 6.9 and the left eye continues to remain plano. So this is a case of anisomyopia. So I'm going to take a minute to try and understand the glass prescription in these kids before moving on to talking about the control. So what is the factor that we need to look at in these patients is what would be the amount of induced anisoconia. And should we undercorrect in view of anisoconia? So, stating this rule called as Darmouth's rule of thumb for anisoconia, if the difference in image size associated with anisometropia is of refractive origin, then anisoconia produced will be about 1.5% per diopter of anisometropia. But since the anisometropia may be partly axial, an estimate of 1% per diopter is more useful. Let me try to simplify this a little bit. So a difference of 1 diopter causes a 2% difference in size of retinal images. A difference of up to 5% is well tolerated. Hence, anisometropia up to 2.5 diopters is well tolerated. Between 2.5 and 4 diopters is tolerated depending on individual sensitivity. And more than 4 diopters, it is not tolerated. So check for diplopia with full correction, okay, and get the axial length keratometry to understand what kind of myopia it is, whether it is an axial myopia or it is a refractive myopia. Now, why is this important? Because anisometropia can be because of axial length and refractive change, and that gets us to another rule called as Knapp's rule. So, if anisometropia is entirely axial and the corrective spectacles are placed in the anterior focal plane, the size of the retinal image would be identical to that formed by an emetropic eye, that is same as the eye of the same refractive power. So, if the child has binocular single vision with full prescription, that should be prescribed. Do not empirically undercorrect, assuming that the child will have diplopia. So, to just sum it up, if the child has anisomyopia, which is axial in origin, full correction is warranted and do not empirically undercorrect the child. Now, do we want to start any therapy to control myopia progression in this kid, and are we justified in doing so? Well, for this particular kid, when I have seen the kid for the first time, I would closely follow up the kid to document progression and increase in axial length and not start the kid directly on any therapy. If progression is documented, then we move on to our control of pharmacological therapy using low dose atropine drops in that eye or even multifocal lenses is a good option. Moving on to the fifth case, a 5-year-old child presenting with diminution of vision since 6 months. The child has had history of night blindness. The child has been using glasses of -3 since 1 year. However, the refractive power has increased to -5 in both the eyes, and child has the best corrected visual acuity is 612 in both the eyes. In view of the night blindness, an ERG was done which showed an attenuated B wave, suggestive for diagnosis of congenital stationary night blindness. Now, in this view, our regular options of myopia control are there. So the axial limb had progressed as was documented by the measurement. Now, how do we intervene for these kids? Can we use low-dose atropine drops, or do we prefer to use the optical method by using, say, peripheral defocus glasses or orthokeratology? So there are few reports that there is this report by Dr. Kothari et al., which has reported selective reduction in the P50 wave on pattern ARG when low-dose atropine drops were used. However, no effect was reported on full-field ARG or multifocal ARG. There are reports contradictory to this. One of this by Dr. Jethani et al., who has stated that there has been no reduction in the ARG amplitudes in high and low contrast gratings. Minimal reduction in the low contrast gratings was reported, but by and large, it seems to be safe on the retina, and there seem to be no retinal side effects. Well, though, as it is a gray area, my personal preference would be to go ahead with a peripheral defocus glass or orthokeratology in these cases as a primary intervention. If I'm not happy with the control, then maybe an addition of the low-dose atropine drops can be considered. Moving on to the last case, a 7-year-old child presenting with diminution of vision for distance, unaided vision was 624. A dry autoref revealed a refractive error of -3.5, which is variable, and cycloplegic refraction revealed a refractive error of +0.5. So what is this? It's not a case of myopia, but it's a case of accommodative spasm, also called as pseudomyopia. So to sum it up, I have included cases in this which do not fall into the regular school myopia or simple myopia cases where we have well elucidated measures for controlling progression. In this category of complex myopia cases, a thorough evaluation can help chalk an individualized plan for each myope. Behavioral modifications, which I have not included overall in the presentation, forms an important and integral part of management in these patients, which includes increased outdoor exposure and some measures to take regular breaks for near activities. And the future of myopia control seems to be very bright, with a lot of research going on and more research pouring in to manage these patients better. Thank you.
Thank you for your patient listening.